I'm going to kick off, then pass you to my colleague Marion, and then over to Paul. And I suppose some of the reflections, first of all, from me, one of the impressions that we've had to date has been we've seen a lot and heard a lot of very good practice in different trusts. In fact, I don't think we've been to a single trust where we haven't had something that's impressed us in terms of what's been done in emergency departments. But what I think we've been struck by was that a lot of those good practice initiatives seem to be very local. They don't seem to have rolled out across the piece, so that and that seemed to us surprising given the level of the commissioning role of the board, the local commissioning groups role, and therefore we wonder first of all whether you think that reflection about good practice being localised and not being rolled out is a fair one. If it's not, how you think that could be remedied?
Okay, Chairman, I'm just going to bring Michael in here for this initial question.
Okay, thank you, Valerie, and thank you, Chair. I am surprised that is the impression that's been given, certainly at the regional board, working with our colleagues in the PHA and working closely with trusts. We do take the lead in a range of service improvement activities in relation to unscheduled care, and certainly and that involves very much the identification and sharing of good practice. For some years now, we identified good practice in relation to unscheduled care, which have become to be known as the key actions. Those are audited regularly by staff in my directorate, and we do share the findings of those and do share what works well in one trust and how they've been embedded perhaps more in one trust than another across the trusts. We also, in our commissioning arrangements, identify what we consider to be evidence-based good practice, and we've been working with trusts to develop unscheduled care improvement plans, and that requires and identifies recognised good practice in relation to patient flow across unscheduled care. We have fairly recently established an ED clinical engagement group that has representatives from clinical staff from all trusts, also the Royal College of Nursing, the College of Emergency Medicine. And again, the purpose of that group is to identify good practice, to share it, and to influence practice. And we have both participated in and led ourselves some of the emergency care summits that there have been over the last year. Certainly participated fully in the ones organised by the RCN and the College of Emergency Medicine. But in September of this year, we organised a learning event that brought together some of the learning from good practice that's taking place here locally to share it, but also from experience elsewhere. So it would be a key part of the board's role in service improvement around unscheduled care. I believe we have identified a range of good practice measures. We're not looking for the silver bullet in unscheduled care. We're not looking for what is the answer to improve performance. I believe those are well established and known. There are issues to do with the consistent application of those, and that would again be part of our work. So, as I say, slightly surprised or disappointed that didn't come across, but I believe we do play an active role in that.
I suppose the second reflection that I have is around on the issue of participation and involvement, and again a sense in which this is rather top down rather than bottom up. I don't think there's anything wrong with it being top down as well as bottom up, but that the first seems to be the prevailing dimension. Some of it seems very good and very impressive, but and again, to give you an example, when we talked to and took evidence from local commissioning groups, I think we got two pieces of feedback really. In one case, there was clearly, I think, a commitment to the idea of participation involvement in the kind of planning of services, not just in terms of having a local commissioning group per se, but then using that as a vehicle for doing that, but very little resources to do it. In a second occasion, when we couldn't find anything in the commissioning plan at all about how they'd involved local people in the idea of planning services, we were told, for example, it had been mainstreamed. And then when we asked, well, can you give us some example of what that actual involvement was that you've now mainstreamed and therefore it's not in the document? There was a kind of resounding silence, and that they couldn't get any examples. So our sense is that in terms of involvement and participation with local commissioning groups and elsewhere, that kind of deeper involvement, while in one or two places we could see it happening, we didn't see very much of it, and we didn't get a sense of the resources to make it happen. Now, again, whether you think that, I'm interested whether you think that's a fair reflection of what we've heard, and if so, are there ways of remedying that? If not, why you think we've perhaps been, if you like, misguided in terms of what we're getting and drawing from the evidence?
Perhaps, Mr. Chairman, if I take that one, if I'm picking your question up rightly, your conclusion is that there's insufficient work through local commissioning, working alongside populations, clients,
yes,
patients, clinicians and others.
Yeah.
Again, as Michael said in response to the first question, I suppose I would be wary about drawing conclusions like that. I can furnish you with any amount of evidence to refute that would actually indicate quite the reverse, both in relation to unscheduled care and more generally in terms of commissioning, in terms of ongoing processes that are in place. Both processes that are facilitated at a regional level, working across the region and with individual trusts and localities to develop regional specifications, but also at a local level, any number of ongoing processes that are in place to understand the needs of patients, to understand whether the current services that are being commissioned are responding effectively and appropriately to those needs, to work with local populations and patients and clients to further develop the services that are already being commissioned to better respond to those needs and so on. So again, I think a risk of drawing conclusions on the basis of maybe one small piece of evidence or in the absence of something to the contrary, I think I would certainly welcome the opportunity if the Commission has a concern in relation to elements of this, that we would have the opportunity perhaps to reassure you.
I'll give you an example, Dana, and I've read the local commissioning group's plans, and in a number of them, I found nothing in them about what had been done in order to, if you like, where their conclusions and their, where they'd arrived at, what the participation was. Mm-hmm. I think with the exception of the Western group's plan, which did do a little bit of that, and in fact, when they gave evidence, they suggested that. I couldn't find it.
But that wouldn't be of itself evidence that it didn't happen, Mr. Chairman. It would be evidence that it's not in some of the plans to the extent that you might have expected it to be. But at the same time, we have, as I'm sure you've seen, the whole commissioning plan for 14-15. It is already a document that runs to several hundred pages. And whilst it's important, I think, to document process, at the same time, outcome is perhaps more important than process when we are trying to keep the thing to a manageable size. So I would be very happy, both in relation to unscheduled care, but more generally, to share details if that would be helpful.
I'm happy to do that. I suppose my comment back is that I think it could have been done in a couple of paragraphs. I don't think we were looking for a 20-page, here's everything we've done in terms of the consultation process. I think we were looking for something that gave a real sense of that, and we didn't find it in the documents. And when we drilled down a bit deeper with one or two of the local commissioning groups, we didn't seem to... The chair, for example, the key official who was working full-time, didn't immediately reassure us that that was there.
In relation to unscheduled care specifically, or more general?
In relation to more general, it wasn't specifically to unscheduled care.
I'm surprised that was the conclusion then, given the processes that are in place.
Yeah. Third kind of area I wanted to explore with you was around severe adverse incidents. And I think what we've gleaned to date is that there are almost like three different perspectives depending on where you are with this, and a tension that clearly arises. You have the healthcare professionals who clearly were saying to us, this is a predominantly learning experience. That's the purpose of the SAI. And therefore, that's where our focus is. Perfectly reasonable. Then families, equally reasonably saying, well, our focus is on something went wrong here, that affected either me or my family members or others, and as a result we were adversely affected, and we really want to know exactly what happened and why, as well as how that might be prevented happening to someone else. But the focus there is very much on the information on what's happened. And then often you get a third focus, which is if the media pick up, for example, on the issue, then they focus on it in terms of, I suppose, newsworthy or other terms. And there seems to me to be, the reality is there are different expectations depending on who is looking in on severe adverse incidents. And they're called severe adverse incidents, which makes it sound something that is clearly very serious. And therefore I wonder whether you think, again, that's a reasonable perception of some of the difficulties that adverse incidents create, and how you might deal with the fact that there seems to me to be different expectations depending on who you are coming into this particular issue.
Okay, if I could maybe pick that up, Mr. Chair. I think that's reasonable that there would be those different expectations depending on people's perspective of where they are in relation to the incident. Certainly from our point of view, and the board took on responsibility for managing serious adverse incidents from the department in 2010. From our perspective, it is very much around the identifying learning, to learn from it, to reduce the likelihood of repeat. But I can understand from a family's point of view where they just want to know, well, what happened wrong and who's to blame for it and what's happening about it. One of the key issues that we've been working on with colleagues in other organisations, including the Patient Client Council and the RQIA, over the last 6 months or so, is to very much strengthen the guidance in relation to family involvement and family engagement, and to make sure families are aware of what the purpose of the procedure is. That has involved a strengthening of the procedure itself, changing the documentation that requires families to be told absolutely explicitly at the outset that the care of them or their loved one has been reported as a serious adverse incident, and the reasons for that, seeking their views on the extent to which they wish to be directly involved. Some families do wish to be involved, some don't, they just want to know the outcome. But having established the extent to which they wish to be involved, then making sure they are involved to that extent, and that may well mean them participating in or joining in some of the discussions and the investigation meetings that take place. It certainly means, as a minimum, sharing the draft report with them of the investigation, but the investigation report will be primarily about identifying if something went wrong, what was it, and how can it be, what learning can come from it, both locally and regionally, how can it be prevented again, or reduce the likelihood of preventing it again. We have finalised draft guidance to issue to trusts on what good engagement with families involves, because it's easy to say you must engage with families and communicate effectively, but does everybody have a consistent view as to what that looks like and what good looks like? So we've developed guidance on what effective family engagement looks like. And perhaps crucially, to address some of the misunderstandings that you've outlined, we've produced a leaflet that all provider organisations would give to the family, the service user or their family at the time of the incident, which explains what exactly is an SAI, what might they expect in terms of the process, and what might the outcome be. So recognise there is the potential for people to have a different view as to what they want out of the process, but from our point of view, and some of that work that I've described that we've been doing recently to hopefully clarify it, is very much around the learning. If it was too much focused around who did what wrong and what's going to happen to them, that would not be conducive to openness and transparency and people being prepared to report when things do go wrong. If it was all very much down a punitive approach, the focus is on the learning and avoiding and improving services for the future.
Okay, two final quick questions from me. One is, again, a an observation. There are a number of very important documents that the board produces and from the department, one of which I think is the quality, the 2020 document. And yet we haven't really seen in any of the evidence, either written or verbally or any of the responses, a kind of sense in which people are drawing from that strategy when they talk about what they're doing on a day-to-day basis. Now, there may be any number of reasons for that, but it's quite surprising again that the kind of wellspring of quality within the board isn't then reflected in kind of what people then talk about, what they're doing on a day-to-day basis. And I wondered whether you think that's an issue for concern or not, or why that might be.
Well, yeah, there are clearly arrangements in place for the implementation of Quality 2020. There's the 7 work streams that are in place. The work streams actually were prioritised from, I want a better word, from the bottom up. So these were work streams against the recommendations that actually staff advised us as the implementation group that they wanted prioritised to take forward, and they are really things that are important to the front line. For example, one of the work streams concentrated on looking at an attributes framework, and it is those attributes that staff believe are absolutely required in order to deliver against the 5 patient and client experience standards and how those could be implemented. So there are 7 work streams which I'm happy to give you detail on that are really fixed on frontline staff and the care that they deliver. In terms of the implementation group itself, there are a number of clinicians who sit on the implementation group. It's chaired by myself and Dr. Harper, who's the Director of Public Health and the Medical Director, Carolyn. But within the trusts, we would have representation from medicine, nursing, social work, right across the spectrum. So again, I think we've made, it has only been implemented for this past year, or the implementation plans are only about a year old. We are looking at the next set of work priorities that we want to take forward. And again, we've put out a call to the service to look for what the service believe are the priorities that they want us to take forward. So it is very much developed from the bottom up, driven from the bottom up, and we have a range of communications that we've put in place to communicate with frontline staff and advise and inform of the progress within those work streams. So, and there's a regular newsletter goes out. It's on all of the trust websites. The trusts reflect the work of Quality 2020 in their annual quality report, which the first one has just been issued by all of the trusts. And again, it's on the websites, and we monitor against the implementation and the action plans against those quality reports. So again, I would say that there's quite a lot of work going on to ensure that staff right at the front line are fully informed in taking forward the work of Quality 2020.
Okay, thank you. One final question for me, and this one arises really from the Minister's evidence earlier this afternoon. And I guess we were slightly taken aback. One of the issues that came up was the alcohol dependency in A&E and the issue of the impact that has on A&E. I think the figure he used was something like 80% of admissions, particularly on a kind of Saturday night in, say, Belfast, for example, have an alcohol dependency issue surrounding whatever the person is presenting with. And he then went on to talk about minimum pricing as one of the key ways ahead. And I wondered whether that perception of that level of impact that alcohol dependency has on A&E is shared in the board in terms of its prevalence, and if so, what are the issues that you're looking at to deal with that?
I'm not sure I recognise it at that rate, Chairman. It may well be that it's getting close to that in terms of attendances that have some alcohol-related element around certain times of the week and certain hours of the day. It won't be at that level, though, I would suggest, but happy to share what the actual number is in terms of attendances and/or admissions. It's an interesting issue for us. Pat and I co-chair a group working with Michael McBride and Charlotte McCardle, the CMO and CNO respectively, as you're aware, around the whole unscheduled care agenda that they co-chair. Excuse me. And one of the things explicitly that we have been looking at as part of that has been what an appropriate stroke different response might be for patients when they arrive at A&E, not just at peak times that you refer to around weekends, but at other times of the week with alcohol difficulties, and distinguishing between those individuals who genuinely have some sort of alcohol dependency distinct from those that have just consumed too much at a particular point in time during the week, and trying to see whether it is possible safely and appropriately to put in place a mechanism which keeps those patients safe and effectively cared for, but perhaps avoids them from being overly disruptive within an A&E department. There's no straightforwardly, there is no straightforward solution to that, regrettably. It might appear populist to talk about things like drying out cells and that sort of a thing. Actually, when you look at the realities and the difficulties of putting in place models like that, there are some people who turn up having had too much alcohol, who have an underlying health condition that maybe bumped their head or whatever, and the risk is obviously of missing that if you simply put them in some alternative facility. Having said that, it is an issue. Again, Valerie and I of late have been on a number of the patient-client council roadshows. This is a consistent theme that is raised. It is an issue of concern to the public, and therefore it is an issue of concern to us, and we will continue to explore opportunities in that regard. So it's a work in progress for us at the minute, Chair. It's not one that we have dismissed at all. It's one that we are seeking to put in place a model, perhaps only for peak times of the week, but even there very carefully thought through, looking at the very limited experiences that have been across the water to see whether we can bring in something similar in Northern Ireland. But there's lots of complexity around that.
Okay, thank you. Marion.
Good afternoon. I have 3 questions, one on participation, one on commissioning, and one on responding to specific client groups. In terms of participation, in the evidence we have received from trusts, they regularly highlighted the 10,000 Voices project as part of their public participation. And I'm wondering, could you outline how the Commissioning Board reviews progress in relation to public participation, determines how it meets your performance indicators, and outline if there's any recurrent funding available to the Trust to progress the agenda set within the 10,000 Voices project?
Okay. Well, I'll start off, maybe Mario, just to tell you about the review arrangements for 10,000 Voices. Again, we have regional processes in place as well as local processes in place to ensure that all of the information that's gathered through the 10,000 Voices initiative is immediately, and I think we talked the last time about that was one of the beauties with 10,000 Voices, is that that the information is received in and acted on a very timely manner, so we can take immediate action on those stories that need that immediate action. In terms of, we have a regional steering group, and from that regional steering group we meet on a monthly basis. The stories are reviewed on a weekly basis. They are mapped against a number of key performance indicators, and in relation to the emergency department 4-hour and 12-hour targets, we would pick up any stories that indicate an element of any discontent around people receiving care that have received for long periods of time within our emergency care departments. We also monitor them against other key performance indicators, such as we look at food and nutrition, at skin care, we look at infection control. So there's a range of performance indicators that we map those stories and what they're telling us against. That happens, as I say, on a monthly basis. We receive quarterly reports in from the trusts in relation to their action plans, which again are monitored against all of those key performance indicators. Then biannual reports are brought both to the senior management team of the board and to the agency management team, and then from there on to the governance committees and through to the public board meetings. So that is a summary just of our arrangements for monitoring. In terms of the funding for 10,000 Voices, when we set out on the initiative initially, we had put in plans placed for funding for 18 months, and the Health and Social Care Board provided that funding. Obviously, the initiative has really been seen to be and proven to be very successful in hearing from the front line and from patients, the patient as they move through our services. So the board had agreed to extend the funding through to March of 2015, and more recently the board approved a business case for recurrent funding, and I was really pleased that that has happened, and I had no doubt that it would. However, like every other initiative that comes through, it is dependent on the funding being made available from the department, and as you know, our funding is made available on an annual cycle, so we will have to await that confirmation from the department, but the board in principle has approved the business case.
You've bid for the money?
For the full amount, yes.
Okay. Thank you very much, Patricia. Turning to commissioning, there's two parts to this question. One of them is to what extent you use the views of clinicians and the public in making commissioning service decisions and in monitoring performance. And the second part of the question is, could you set out how the Trust bid for new monies, and where a Trust overspends in one particular area, what is the board's role in monitoring and analysing the implications of the overspend, and what financial controls you exercise when overspend occurs?
Okay. Thanks for that, Maren. A couple of things to pick up then. I think the first question around the involvement of the public, of clinicians and so on in commissioning comes back to your question, Mr. Chairman, as well.
Yep.
What I will do, if it's helpful, is share with you some written material after this. I think it would be not what I would wish to be the outcome of this process, that you reach a conclusion on the basis of income, and I'm sure it wouldn't be for yourself either, to be a good outcome, that you reach a conclusion on the basis of incomplete evidence and material. So certainly I'll do what I can to make sure that you have everything that would help in that regard. I think in terms of our involvement of clinicians and the public and so on, I don't think we can ever do too much of that. We shared with you when we met previously some of the things that we're doing. I will share with you in writing what we are doing now across acute care, across other programmes of care as well. There are ongoing initiatives to meet with the public in general. I talked about some of that, events organised by the Patient Client Council that are attended by the top of the shop from across organisations, from the head of chairs of LCGs, by Valerie, by myself, by Deputy Secretary or Permanent Secretary within the department, meeting with the public across a range of issues, very much their agenda on the evening. So there's been a whole series of those events run recently. So you've got events at a regional level that are run or attended at a regional level but run locally. You've got any number of events either on issues specific matters that are organised by LCGs within localities. You've got events that are run at a regional level but sometimes again discharged through local events to work through particular matters. A lot of the stuff around paediatric cardiac surgery, so very much a regional issue, but to be as accessible as possible, we ran a series of events locally in that regard. So a series of different things that we would wish to do and do to work through with patients, with clients and with clinicians. And then lastly, also in a number of things I've been directly involved in myself, where we face particularly thorny service issues, where there is no straightforward solution, where it's clear that we're not adequately responding to the needs of the public, where clearly we have and are working in a very resource-constrained environment, where effectively we've just cleared the decks with clinicians, sat down with them for several hours asking them to work with us, as they have done very productively and constructively, to put in place very different service models than the ones we have now. A concern I would hear on occasion from clinicians is, not because anyone goes out of their way to make the systems or processes complex, they just inherently are. The very nature of it, where we're involving different professional groups within trusts. You have management structures within trusts, governance structures within trusts, and then the equivalent structures and so on within commissioning as well. And it can seem quite hard to see the wood for the trees. And to cut through that some of the times, what is necessary is to get everyone in a room and just go back to first principles, putting the patient at the centre of that. What is it we're trying to do for those patients, and how might we do it differently? And we've come up with, I think, through those processes to date, and again, if it would be helpful after today, very happy to share with you areas where we have progressed work in that way. We have come up with models that we would in months or years not get to and not secure the same buy-in to if we had sought, as you refer to it, on a top-down basis to say the answer is this because they're doing this in Manchester or Glasgow or somewhere in Europe. Far better. The clinicians nearly always know that. They don't need us to tell them what best practice is. They're just either they haven't been incentivized or been given the opportunity to bring forward those models themselves. So that has been a helpful process too. I think the last and quite technical question you're asking, Marion, was around the what do we do in circumstances where there is an overspend in a particular area. Again, we're very live to this issue. It does come back to what is commissioning. Commissioning at the end of the day is about identifying patient needs and client needs. It is about developing service models in response to those needs, and it is about then commissioning that service model from one or more providers. Having done all of that, the only circumstance in which what you're describing there can arise is that that we understated the needs of patients, and or B, a trust is incurring more cost than it should be incurring in responding to those needs. And sometimes see it can be a little bit of both. Again, I'm happy to share details of this. This is a very live issue for me, working with colleagues, including one colleague who's not here tonight, Paul Cummings, our finance director. We have had, as recently as the last 6 weeks, we have met with each of the LCGs, going through each programme of care, looking at precisely the issues you're flagging up, Marion, where trust may be apparently overspending in a particular programme of care, to understand what that is. Is that genuinely an issue where we are simply not commissioning sufficient service from that provider in response to need, or is it a combination of that plus a degree of opportunity to reduce costs, and by exception in some cases it can be that the trust may simply be delivering more activity than we would see would be necessary or appropriate to respond to the needs. So a whole combination of things. When that happens in the middle of the year, we sort of find ourselves where we find ourselves. There's not very much that can be done. You start the year in good faith expecting to commission 1,000x to respond to a need of 1,000. If a trust is either incurring more in delivering 1,000x and or delivering 1,100x, that becomes an issue, to answer your question, that we would pick up as part of discussions for the following year, where actually we had got the needs wrong and it's not an exact science as you'd expect. Then clearly we would seek to reflect that in our agreement with the trust for the following year. Whereas for a different reason, then we would work with that trust to get that back into balance going into the following year, so as not to end up in a permanent situation where budgets were being skewed away from one area of need towards another area of need, because that clearly wouldn't be a sustainable position for us.
Okay, thank you. And finally, we've noted in some of the LCG plans that some groups, such as children in care and ethnic minorities, are not explicitly referred to in their commissioning intentions. And we're wondering, how does the board address that, and also how can you ensure that funding is targeted to address the needs of those groups? And following on from that, part of the commissioning priorities, plans and budgets are addressing social exclusion and disadvantage, and we're just wondering, How are those explicitly stated by the board in your commissioning arrangements?
Okay, maybe if I pick up the first couple of bits of those, if that's all right, Laura, in terms of, again, if it would be wrong to draw a conclusion that because there wasn't an explicit reference to children in care within a local commissioning plan or a specific reference to ethnic minorities, that somehow that wasn't prioritised and appropriately funded by the board. Children in care, because of FNULA's responsibilities and the safeguarding responsibilities that go with that, the board tackles as a regional issue, so I wouldn't expect it to be heavily referenced within individual local commissioning plans. You need to read the commissioning plan as a single thing in itself. It is the commissioning plan that is signed off by the board, that is put to the agency for their agreement and then put to the minister for sign off, rather than any individual part of that plan. And there's very extensive material within that plan in relation to children in care. In terms of ethnic minorities, again, we're very mindful of our responsibilities in relation to groups that potentially could be disadvantaged. There would be extensive references within the plan and within the screening element of that plan to the inequalities that exist and our responsibilities in terms of Section 75 groups and so on. We've of late been very explicitly looking at some of the interpreting service needs of some minority groups within Northern Ireland. They have grown exponentially in recent years in parallel with the growth of the immigrant population within Northern Ireland. And we have fully met those needs, indeed are looking at different ways of responding to those needs and better again meeting those needs going forward. So very mindful of our responsibilities in that regard.
Maybe if I could just add, I mean, I think there's a whole raft of mechanisms, Marion, for dealing with issues that are specific to specific groups, and also the needs of those groups integrated into some of the plans that we're taking forward. So, for example, children and young people, we have a regional commissioning team that will address children and young people's issues specifically. Mostly the looked after population, the children who are known to social services. So within that context, we would build in issues around children with disabilities who are also looked after, children from ethnic minorities who are also looked after. So it's not a standalone issue as such, it's integrated into our thinking around that particular population. So I think as well there is the children and young people's planning process, which is a multi-agency approach to planning to meet the needs of children and young people. And again, we have a raft of working groups around that. One group looking at children with disabilities specifically, one group looking at the emotional and mental health and well-being of children, and another looking at the BME child population. So internally we do it for health and social care, but we do it with other agencies in terms of the whole of the population and how, on a multi-agency basis, we can actually meet the needs of those specific groups of children. I think if you then get into the mental health arena, I could point to something similar under the Bamford Task Group. So it's really saying to you that there's a range of ways in which those plans are brought forward. And all of those plans are public information. They're all on our website, aligned to the specific work of those groups.
Okay, I'll pass you to Paul.
It's clear from your reactions that that you think we might have got the wrong end of the stick about certain points, and that's why we wanted you back here, so you had the opportunity to put us right. So thank you very much. Now, it might be that I'm going to retraverse some of the ground that Marion just touched on, so please bear with me if you don't mind. Because I understand that there are other documents where these issues around socially excluded groups will be addressed. But what I don't understand is how they're funded. Can I explain? my confusion, because if I take you through it, then perhaps you can educate me. So, I look at the draft budget, right? The recent draft budget, and in it there's a reference to social exclusion levels in Northern Ireland are well above other parts of the UK, and it says that a significant number of households have experienced intergenerational poverty. And then later on, I'm just picking out little bits, later on, priority 2, creating opportunities, tackling disadvantage. And then later on, delivering social change framework was set up by the Northern Ireland Executive to tackle poverty and social exclusion. And I could go on. You get the picture. Social exclusion, disadvantage, really evidently a big deal for the executive. Now, of course, I understand that the board can't address and solve social disadvantage and social exclusion. This is immensely complicated. Nonetheless, you have a contribution to make. I'm sure you'd agree, and you would wish, I would imagine, trusts to be very cognizant of social exclusion and disadvantage, and wish their interventions to address those issues so far as possible. Okay, so what I think the executive isn't only addressing are the Section 75 groups, which someone referred to. It's addressing social exclusion and disadvantage goes beyond Section 75 groups. So then I go to local commissioning plans, and I'm looking to see, well, that's great. Northern Ireland Executive, social exclusion a big deal, disadvantage a big deal. So then I look to the local commissioning plans, and I'm expecting to see something, and maybe this is my error, which is why I'm boringly laying it out for you, that I expect then to see some recognition that the commissioning plans should be designed in such a way as so far as possible address the disadvantage that some groups suffer. So I looked at the local commissioning plans, and I mean, I've just pulled out one, but I think I could have pulled out any of them. And in the early pages, there's a reference to important scene setting. It's in sections 1 through to 3. Population and need, key success, key challenges. It's about 8 pages long. And here, there is a discussion about multiple deprivation. So that's good. That's what I would expect. There's a discussion about multiple deprivation and social exclusion. Also PPI, but let's not go down there. Let's stick with social exclusion because that's already been discussed by my colleagues. And then continuing in that local commissioning plan, then there's section 4, which is 60 pages long, and that sets out the commissioning intentions. And you're very, very familiar with this, much more than I am, from cancer care through to unscheduled care. And as I understand it, that's what's funded, I think. But you'll correct me if that's wrong.
Services are funded.
Sorry?
Services are funded.
Right. So am I right that under those commissioning intentions, it's things that fall under that will be funded? But you correct me in a moment if I'm wrong, okay? And it looks like from your face that I am wrong. So please
No,
bear with
that's my
me.
normal face.
No,
sorry.
no, I'm
So
think on the straight and narrow
what
so far.
what I don't see are commissioning, in quotes, commissioning intentions that, I don't know what word to use, encompass, take account of, accommodate. That sounds a bit pejorative, but I don't see commissioning intentions that encompass tackling social exclusion and disadvantage in relation to the services provided. So I think that's a bit odd, okay, but I'm sure I'm missing something. So then I think, well, why isn't this issue of social exclusion and disadvantage there in the commissioning priorities? Because obviously it's very important to the executive. So then I go to your plan, right? The board's commissioning plan. And there I see tackling inequalities and preventing ill health is there, page 26. So there's a recognition of social exclusion, which is really important and greatly esteemed. That's quite early on in the plan. And then we come to section 4, the regional commissioning priorities, which go on for about 100 pages. And there I don't see tackling disadvantage in the regional commissioning priorities, or taking account of disadvantage. Maybe that's a fairer way of putting it, taking account of disadvantage in the regional commissioning priorities. And if that is right, then that's why, of course, those issues aren't in the Trust's commissioning intentions either, because they'll be following the cue from yourselves. So, perhaps I'm just misreading it. If I am, I apologise. But to try and be as pithy as possible, what I was expecting to see in the regional commission priorities was a priority reflecting the executive, a priority that services had to be designed to address disadvantaged groups and social exclusion. And that's what I don't see. I'm not saying you're not doing it, okay? I'm just saying in the papers I don't see it. Now maybe it's because it's in another document. That was one of your points earlier. But those other documents, do they give rise to funding? Okay, so if you could disabuse me of my ignorance, I'd be most grateful.
Well, perhaps if I could just outline one key commissioning priority that we've been working on for 3 years, which is the resettlement of people with learning disabilities and mental health issues from long-term hospital into the community. So there has been a significant funded programme, planning, piece of work that we're being taken from. We're actually in the last year of that process. So, and I'm trying, that's just the example. I believe, and you might correct me, but I believe that is tackling social exclusion, it's tackling social inequalities, and it's providing people in one of the disadvantaged groups with the opportunity to experience what the rest of us take for granted: having your own home, having your own friends, living in the community, doing daytime opportunities, activities. Okay. The commissioning plan, as I understand it from memory, and I don't have it in front of me, has a reference to the resettlement programme as one of our key priorities. But maybe what it doesn't do for somebody reading it for the first time is go over the history and link it with the regional strategy as to why. Dean might want to comment on that, but I'm trying to understand how somebody reads the commissioning plan and thinks it's not explicit about tackling social exclusion and inequalities, when we obviously feel we're doing significant amounts of work around particular groups of individuals. That is the key priority. That's the reason why we're doing it.
So that little neat example, thank you for it. It helps me understand. So where's the money come for that? For those, whatever the right word is, those interventions?
Well, it's programme for government. It's come from the department, and it's read across then into the board's commissioning plan. So the board allocates the money against the plans to make sure that those people are appropriately resettled from hospital into community. Because the board is the commissioner, and commissioning isn't all about new money, it's about redesign and doing things differently. The funding then that we retract from the hospital services that are no longer needed because people are living more in the community, we can use for other things, and that would be part of the commissioning task. Does that? No?
Yes, no, that's...
Get nearer to a clarification, that's perhaps?
So there are, in addition to the commissioning priorities, in addition to the local commissioning plans, and in addition to your commissioning plan, I need to read, and that's fine, I'll try and do it. I need to read these other documents in relation to which money is attached, which are designed to try to roll back social exclusion and disadvantage.
I believe that to be the case. So resettlement is one. We've recently published a framework for daytime opportunities for people with learning disability. The principles of social inclusion and normalisation would be built into that plan, and there'll be an amount of, well, there'll be a financial plan to sit alongside the service redesign, and that's how we would do it. Now, should the commissioning plan have more detail in relation to what's in all the other documents, you'd be running to double the size of what it is,
Yeah.
but maybe reference should be made. I mean, maybe you're right.
I mean, if it's being done, fantastic, and I need to do more homework by the sounds of it. I thought the sort of the key instrument to ensure that the trusts do what you want them to do. I thought the key instrument was the local commissioning plans, and it sounds like it's local commissioning plans plus a whole lot of other stuff. I should stop soon, but there are these sort of parallel programs to which you've alluded. So what's the accountability in relation to those? Please.
Fionnuala wasn't implying that it was a parallel. I wasn't saying that it was a parallel program. It's degrees of detail and timing as to how things are reflected at a particular point in time. Resettlement has been around for several years now, so it wouldn't appear with a fanfare within a commissioning plan for 14-15. It would have been, which is to complete or substantially complete the resettlement programme by March 2015, which is the end of a very, very long journey for a number of practitioners and indeed clients that have been involved in that process. I think more generally, the point around how the plan explicitly tackles social exclusion, I would make a couple of points. It's implicit in many parts of the plan, but maybe what you're suggesting could be helpfully made more explicit within the plan. And the accountability loop for all of that work is the accountability loop, which is what are the needs, what's the service model? We commission that service from providers. Part of that's the trust, and it would be wrong to suggest, I know you're not, that trusts are the only means of us promoting social inclusion. Clearly there's other third sector providers that we also seek to do that through as well, and we have accountability mechanisms with them, as we have with trusts, to ensure that we're getting what we're paying for, bluntly. But the whole issue of social inclusion, of tackling inequalities, again, it's a bit like the involvement of patients, clients and clinicians. We can never do too much of it. I think what we sought to do in recent years is to be very disciplined and systematic about doing that. And in as far as there are data to support that, we seek to use those data. Insofar as we can straightforwardly identify the relevant populations and so on, we seek to engage with the relevant populations. And as far as we can draw on relevant published literature, we seek to draw on relevant published literature. It would be wrong, though, to jump straight into a local commissioning plan. Just to say again, the significance of looking at the commissioning plan as a whole is what I would ask you to do. For the reasons Fionnuala said and I said earlier, the plan is already, I would argue, and others may argue, too long. We seek to follow the format prescribed within the department's commissioning direction. Everything that we put into a local commissioning plan by definition is a thing that has to appear 5 times. So as far as possible, with some issues, we seek to cover them once in the regional element of the plan. What that leaves us open to, though, is someone, as you have yourself, you pick up a local commissioning plan, you expect it to be a thing with a beginning and a middle and an end and all encompassing. It's not that. It is a part of a wider document.
Documents. Part of a wider document?
No, it is part of a wider document. The local commissioning plan is part of a wider document. The history of some of the issues and priorities that appear within the thing that is the commissioning plan and the context for that commissioning plan is certainly part of a series of wider documents. Programme for government being one, the commissioning direction being one, any number of departmental policy documents being others, any number of board policies and documents being others.
But as someone whose staff is doing
Yes.
all of this
Yes.
work, not on their own, but with others. The commissioning plan is the core document. What I'm suggesting to you is that there is more detail in the framework documents that support the commissioning plan, and perhaps in some of those, the rationale around social inclusion and disadvantaged groups is set against each of those frameworks, which are specific to a group of disadvantaged people. But definitely the key priorities are in the commissioning plan.
Okay, I think
Does
you've been very patient. Thank you. Very
Well, I'd
much.
like to think that was coherent,
Yeah,
that you understand us better.
But the very interesting thing, I was about to offer an observation, which is, as somebody who's read quite a lot of these documents, and I think Paul's probably not that far off the mark, because I think the point which is being made, which is about tackling disadvantage, health inequality, social exclusion, is actually, do you, when you read the documents, see a coherence there? There's clearly a broad intent, which is beyond, frankly, the department's bodies elsewhere. And I'm not sure that I pick up that coherence from reading, and as somebody who's interested in all of that, and I take on board entirely and agree with Paul, the issue is not then, is that work not being done? Because I think actually I could pick out examples of where I know it's being done, and the learning disability one is a very one close to my heart, as I was involved in kind of that from my old. But do you see the coherence of all that in the overall scheme of things? And I'm not sure the answer to that is yes. That's my observation, and I'm again as happy to be disabused of that notion, I think, as Paul. I think it's probably chance for you to have the last word, because we've called you back. Is there anything that you think we either haven't covered, or you haven't felt you had sufficient say on, that you want to kind of finish? And I take on board Dean's offer to provide kind of further documents, and we'll do that, and that's very welcome, and I shall spend some more time reading. But is there anything else that any of you points you'd like to make that you think we either haven't dealt with or
Can I
haven't dealt
just
with
make one
sufficiently?
comment about participation?
Yes, sure.
Because I believe it's something that the board and the PHA takes very, very seriously. And it's not just about clinical engagement, it's a collaborative arrangement with lots of stakeholders to inform commissioning, to inform service monitoring and service redesign. And more recently, we're moving to the notion of co-production. So the mental health care pathway that's just been published was absolutely co-produced with service users, with carers, and with clinical and other professional staff, as well as the board and the PHA. So I just wanted to make sure that, because for me, the benefit of clinical engagement is being able to sit that alongside service user experience of our services. So I just wanted to make that point in terms of more collaboration, not just clinicians being involved, but a much, much wider stakeholder group.
Thank you. Valerie, can I thank you and your team? We put you through your paces based on, as I say, the reflections that we've had, and this will allow us to reflect again then on what we've heard and read, and we'll do some more reading once we get the additional documents. So that's been really helpful for us this afternoon. So thank you. Thanks very much for taking time out from what I know are busy lives and in trains. So thanks very much.